It's important to understand the anatomy of the biliary tract because it can then help you work up the cause of an obstructive LFT derangement. Here we have the liver, and then within the liver we have the left and right hepatic ducts, which form the common hepatic duct. We have the gallbladder here, which forms into the cystic duct and joins the common hepatic duct to then form the common bile duct, which then goes and joins with the pancreatic duct and goes into the duodenum at the level of D2 through the sphincter of Oddi. The duodenum wraps around as shown here, and the pancreas sits in here with the head behind D2. The most common form of biliary obstruction is usually from a gallstone, which can form within the gallbladder and then cause cholecystitis or inflammation of the gallbladder. The gallstone can get impacted in the neck of the gallbladder, and from there, if you imagine the cystic duct curving around here, can then block off and cause biliary obstruction that way, which is called Mersey syndrome. Or the gallstone can make its way into the common bile duct, and a mechanism to try and remove this stone is to contract the biliary tract, which therefore causes severe biliary colic, a prolonged cramping sensation which patients present with if they have biliary tract stones. The stones can then make their way down towards the sphincter of Oddi. When they get close to it, they can simultaneously block off the common bile duct and the pancreatic duct, and because it's blocking the pancreatic duct and the release of pancreatic enzymes, this can then lead to what is called gallstone pancreatitis. Sometimes the stone can pass on their own into the duodenum and then can be excreted through with the feces, but sometimes the stone remains stuck here or anywhere more proximally and will need a procedure called a ERCP, or endoscopic retrograde cholangiopancreatogram, to be able to visualize the obstructions as filling defects in this biliary or pancreatic duct tract, and then to physically go in to remove these stones through an endoscopic procedure. In gallstone pancreatitis, when the stone is distal in this position here, you will get an elevated lipase, and so you can use the lipase test to sort of tell where the stone is in the biliary tract, such that if they present with biliary colic, that tells you that the stone is probably somewhere along here, and then if their lipase is elevated as well, that tells you that the stone is probably quite distal and is blocking off the pancreatic duct as well. If the bilirubin then begins to fall and their pain starts to resolve over the following days without intervention, then this may suggest that the stone has passed on its own. As you can imagine, if there's a blockage along the biliary tract, then proximally to the blockage there's going to be biliary dilatation, as there's a buildup of the bile, and this can be detected with imaging and is one of the best markers for biliary obstruction. The normal bile duct is usually less than 7 millimeters, but can be up to 1 millimeter per decade of the patient's life. But anything more than that is generally considered to be abnormal and possibly a sign of biliary obstruction. If the biliary obstruction is severe, you can also get intrahepatic biliary dilatation, which can be quite obvious on ultrasound. And sometimes if you get a good view of the distal common bile duct on ultrasound, you can see the stones that are causing the obstruction. The liver and biliary tract ultrasound is therefore a useful initial test to do because it can see stones which are echogenic and can assess for intra and extrahepatic biliary dilatation. A CT scan of the abdomen and pelvis will be able to detect biliary dilatation, but it usually won't be able to pick up gallstones because gallstones are usually cholesterol based, which are low density and can be similar density to the surrounding bile, which makes it difficult to detect on the CT scan. The best non-invasive imaging is probably that of the MRCP, which stands for magnetic resonance cholangiopancreatogram. or pancreatography, which is an MRI scan that can pick up filling defects within the biliary tract, where the filling defects can be suggestive of obstructing stones. Similarly, an ERCP can also pick up the filling defect, and the advantage over the MRCP is that the ERCP can also be therapeutic in that the stones can be removed during the procedure. Although the disadvantage is that it is an invasive procedure, albeit endoscopic, and has a not insignificant risk of ERCP-related pancreatitis if the pancreatic duct is cannulated and irritated instead of cannulating the common bile duct. Sometimes instead of stones, you can get malignant obstructions such as cholangiocarcinomas or a neoplastic mass arising from the biliary tract. And in these sort of situations, if there's significant biliary obstruction that needs to be acutely relieved, then the ERCP procedure can also insert a biliary stent, which will relieve the obstruction and allow the bile to flow through, which will reduce the risk of biliary tract infection, which is known as cholangitis, which can complicate biliary obstruction such as from gallstone pancreatitis. Apart from gallstones, you can also get similar pathology from biliary sludge, and while surgical removal of the gallbladder or cholecystectomy is the treatment for gallstones and is standard of care to have a cholecystectomy as an inpatient following presentation with gallstone pancreatitis, cholecystectomy does not preclude obstructive biliary disease because some people can still form sludge or microstones or microlithiasis, so to speak, within the biliary tract, which can still cause biliary obstruction. And so this should still be suspected as an etiology for an obstructive LFT pattern, even if someone has had a previous cholecystectomy. You can also get abnormal intrahepatic ducts, which can then cause intrahepatic obstruction, namely from things like primary biliary cholangitis or primary sclerosing cholangitis, where the abnormal intrahepatic ducts can be visualized with an MRCP, and if there is normal imaging but a high clinical suspicion remains for primary sclerosing cholangitis in the setting of an obstructive LFT pattern, and for example an associated disease like ulcerative colitis, then a liver biopsy may be able to pick up a histological diagnosis of small duct primary sclerosing cholangitis. So to summarize, understanding the anatomy of the biliary tract is important to understanding the various pathologies and terminologies such as cholecystitis for inflammation of the gallbladder, cholelithiasis for gallstones, choledocholithiasis for stones within the common bile duct, and cholangitis for inflammation or infection of the biliary tract. So to put everything together, I want to go through an approach to LFT derangement. As with everything in medicine, it's very important to take a good history and do a good physical exam because there are oftentimes many clues in the history. For example, whether they've started new medications which are potentially hepatotoxic, whether they have a significant alcohol intake in the past or acutely, and whether they've had particular exposures which would put them at risk for parasitic infections or viral infections such as from contaminated food, water, or intravenous access, and family history for the genetic causes of liver pathology. Jaundice is one of the main signs of liver failure, including in acute liver failure, and often correlates with a bilirubin level of more than about 40 or 50 micromoles per liter. But there can also be signs of chronic liver disease such as clubbing, ascites, spider nevi, etc., which will distinguish acute from chronic liver disease. Then, with the history and exam findings in mind, we can look at the LFT derangement and try and identify the pattern and the degree of severity. As in, is it only mildly elevated, 2 to 3 times the upper limit of normal, or is it moderately elevated up to about 1,000 or is it severely elevated where the ALT and AST can be several thousands. And based on the pattern and severity, we can then form a more narrow differential diagnosis and then investigate further based on our differential, which we've discussed and is summarized here. Specific tests include things like an alcohol level, drug levels like a paracetamol level, and correlation with a nomogram, echocardiogram if heart failure is suspected, or a abdominal ultrasound with a Doppler if thrombosis is suspected, bloodborne virus serology including hepatitis A, B, C, and E in the right circumstances, such as in pregnant women or people who've been exposed to unsanitized water, autoimmune serologies such as the anti-smooth muscle antibody and the anti-LKM or liver-kidney microsomal antibody for autoimmune hepatitis, or the anti-mitochondrial antibody for primary biliary cirrhosis or cholangitis. You can also do genetic testing for hemochromatosis, looking to see if they're heterozygous or homozygous for the C282Y and H63D mutations in the HFE gene. And you can look at the alpha-1 antitrypsin levels, particularly looking for very low levels in alpha-1 antitrypsin deficiency. Iron studies can be done to look for a marked elevation of ferritin, which can be due to hereditary hemochromatosis, inflammatory states like chronic autoimmune disease, or chronic liver disease from alcohol, or other causes of iron overload such as from chronic hemolysis from thalassemia or from recurrent blood transfusions. The hallmark of hemochromatosis and iron overload states is a high transferrin saturation, usually more than about 45%, which distinguishes it from a ferritin elevation in the setting of an inflammatory state where the transferrin saturation is usually reduced. Therefore, if there's iron overload with an elevated ferritin and transferrin saturation, you can proceed to investigate for hereditary hemochromatosis by doing genetic testing to look for HFE mutations, particularly C282Y and H63D. You can do an alpha-1 antitrypsin level to look for a low level to suggest alpha-1 antitrypsin deficiency, and you can do a ceruloplasmin level looking for a low level which may suggest Wilson's disease. The patient also has neurological symptoms with hepatic failure, but this typically occurs in young patients. Imaging of the liver and biliary tract remains an important part of the investigation for LFT derangement, as it can pick up a number of the differential diagnoses as discussed. Generally speaking, an ultrasound of the liver and biliary tract is the best test, particularly for biliary obstruction, although if you're looking for parenchymal liver pathology, a CT scan can also be used, although it's usually not as good as ultrasound for biliary obstruction pathologies. An MRCP can be a useful test to look at the bile ducts, to look for both intra and extrahepatic biliary obstruction in the form of filling defects. The main role of the MRCP in the diagnostic workup is really to try and avoid an ERCP by showing that there is no biliary obstruction in the setting of low pretest probability. If there's already evidence of biliary obstruction, such as a stone visualized in the distal common bile duct on ultrasound or even on CT, and the patient remains persistently symptomatic with persistent bilirubin elevation, then you could make the argument to bypass MRCP and go straight for ERCP, because you can make the diagnosis on the ERCP and provide the therapeutic intervention to relieve the obstruction, which the MRCP would not be able to do. MRI scan of the liver or pancreas is particularly good to look for things like malignancy. It is so good that we can often make a diagnosis of hepatocellular carcinoma now radiologically, although biopsy should still be considered if the findings are not clear. Because of the close relationship of the pancreas to the biliary tract and liver, it's important to assess for pancreatic pathology as well, such as pancreatitis, particularly gallstone pancreatitis, with a lipase and the appropriate imaging. And if through the above workup the diagnosis still remains unclear, then a liver biopsy may be considered if appropriate for clarification of the diagnosis with histopathology. Ultimately, you want to treat the underlying cause of the liver failure, and particularly if the liver function test derangements are severe, you want to assess and monitor for the liver synthetic function with the bilirubin, prothrombin time, albumin, and the platelet count, because these are the true markers for liver failure. While in acute liver failure, you want to prevent the most feared complication of hepatic encephalopathy, and the best way to do this is to try and prevent the buildup of nitrogenous waste products by ensuring the patient has frequent loose stools by giving them lactulose and rifaximin, although this is a more important treatment point in chronic liver disease. If the liver failure remains severe and persistent despite treating the underlying cause, then liver transplant may need to be considered. And with that brings us to the end of this video. This slide with the approach to LFT derangements summarizes the key take-home messages that we've discussed throughout this video, and is there for you to review. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.